Welcome, everyone, to the Industry Matters podcast with the VGM and Associates. This is Ronda Buhrmester. I'm the Senior Director of Payer Relations and Reimbursement. And I am super honored today because I have one of my work buddies with me, as we call each other, from ACU-Serve, Noel. Neil, in case you didn't, if you're listening and can't see us, I have Noel on the line with us. Normally you see us at a show presenting together, maybe a webinar presenting together, or maybe we're on our own, but I'm super honored to have Noel here today. So you all know who I am with VGM as a senior director. I've worked with our suppliers for many, many years now at VGM. I'll go ahead and let Noel introduce himself. Welcome, Noel.
Hi, Ronda. I'm extremely excited to actually be here with you today and the VGM members. I am the Chief Compliance Officer at ACU-Serve. ACU-Serve is an end-to-end revenue cycle management company. I love co-presenting with Ronda. We always have a lot of fun while educating suppliers because we have like passions in educating suppliers on sometimes seemingly complex regulations from Medicare's and other payers. And sometimes it's just a perspective because we've been doing this for a very long time. So I always welcome the opportunity to collaborate with Ronda on any interesting topics or even topics that have been on the books for a while, just folks need a refresher on. So happy to be here and thanks for having me, Ronda.
Absolutely. Absolutely. Just a little funny story for those that are listening to our podcast is we have a lot of nicknames for you and I, right, in the industry. There's the Midwest Association at MAMES. They love to call us peanut butter and jelly, so we'll play along with that, right?
Yeah.
Then we've heard people call us the professors of DME, which we love too because we love educating. So there's a lot of nicknames that we love.
We love it.
Yeah.
And we appreciate the feedback that we get from all of the attendees at our webinars and the listeners of our podcast or attendees in our in-person session. You guys are really the motivation behind what we do. So we appreciate all the feedback, good, bad, and indifferent. So
absolutely. Yeah. Always here to help and try to make sense of these policies and articles and nuances that hit us from CMS or any other payer for sure. So we're always here to help. And today we decided to bring a topic to our membership and to any of those listening to the podcast regarding lymphedema compression therapy. It was an act at one time that got instated as a DME benefit. So we now have this under a DME benefit and we've had for a while. So we thought we'd talk about it today versus doing our webinar at this time anyway, because we just had a few updates we wanted to share and clarifications. So I'm sure everyone's open to that, to listen to this discussion on a podcast format. And then you can share this obviously with any of your peers and listen to this as many times as you want, because we love that too, that as long as it's helping you. And with that, we thought we'd kind of just start talking about the market because I know there are suppliers, and Noel has heard this too. There are suppliers currently in the market of lymphedema compression. I also hear, and I know he hears suppliers that are considering it, but they're unsure. I'm just curious, what do you share with people when they say, hey, should I get into lymphedema? Because I always tell them, look at your market, look to see if you're going to get the referrals, and not just lymphedema. This goes for any product category, right? What's your market look like? Talk to referrals. Is there a need for it? Who has the market? I mean, what are you sharing with folks when they ask about it?
Yeah, I mean, similar to what you've said, Rhonda, you have to analyze your market to make sure that it's the right product. Whether you are a new DME just getting into this business, I mean, I've had a lot of those conversations over the last couple of weeks and folks looking at the appropriate product category, or you are an established DME and you're looking to add lymphedema as a new product to your offerings. And it's really evaluating the market to see if there's a market for it. I think personally there are more demand than there are suppliers at this point. I'm still hearing rumors from the lymphedema advocacy group of people are unable to find providers to be able to fulfill their orders. So I still believe there is an opportunity, but there's still, like anything else, you have to evaluate the reimbursement. There are a few manufacturers that offers a large selection of products, analyze the margins, and if it makes sense to you from a dollars and cents perspective, then it is something to pursue. But also understanding the documentation requirements and the compliance requirements. And Rhonda, as you know, and have said, this is a benefit that was created by Congress in December of 2022 and was implemented as of January 1st, 2024. So we had a whole year. But as it stands today, there's no actual formal LCD. It's just coverage for diagnosis. And it's the diagnosis codes are ICD-10 codes are contingent upon coverage, right? So not a lot of guidance to go on, but suppliers who are going to enter into this space have to be very documentation conscientious. Make sure that the medical necessity is documented for each of the products. So it's not just the margins, but also the compliance piece in documentation compliance and navigating the reimbursement challenges. It's a little bit easier for Medicare, right? Because Rhonda, we've seen a lot of guidance that has been published, but we're still seeing some challenges on the Medicare Advantage side and perhaps the Medicaid. So understanding also your target audience. Are you going to be predominantly Medicare? Makes it a little bit easier. But if you're talking about other payers, just expect some challenges. Some of them are paying better than others, Rhonda. That's what we're seeing. But some of them are still struggling with some of the nuance where it's a little bit more refined and detailed with the Medicare fee-for-service business.
Yeah. Just a couple of notes on that too. When you talked about, the limited guidance that we have, I'm all about keeping it limited on the guidance. And I say that because when we push to get a policy and LCD, we use the words, be careful what you ask for. And we've seen that in other areas where we pushed for things and, whether it's an LCD or certain information that we're looking for, and just be careful what you ask for, because in the end, you're not going to like it. Right. So the guidance that's out there, I feel like it's great guidance. What would else do they need to put in a policy? And all they could do is make it more restrictive for our patients to get lymphedema, which we certainly do not want. So take for what we have out there and use that and know that it's not just an LCD that we have to follow, right? We have the supplier manual. We have the, all of those are based on CMS IOM manuals, but we have to look at medical necessity. And that's always the basis of it, right? So records, the order is the easiest part to capture and because we have a lot of control over what we can do with those, but the medical records, right? So
And to your point, Rhonda, I agree. A policy is definitely something that folks strive for, but also understand that this is a new benefits, right? So I don't think it's practical for the DME MACs within a year to be able to construct a policy. One, there's a lot of accessories that are built on different cadence, and they are probably going to need a lot of claim data to be able to even establish limits on some of the accessories, right? So, or even to code that. So it's a mammoth task for the DMDs to really create a policy that is all encompassing. And to your point, I agree. I think that there's sufficient guidance here. It's contingent upon these diagnoses. And as long as the clinicians document the medical need, I think they're going to be okay. I've only heard of one Medicare audit across the industry, and it's one provider that have gotten a UPIC audit just recently. And that's the only one. And I have access to a wide network of lymphedema providers. And so it's not something that is common, but I think as long as folks actually document, Ron, and you and I mean, we're singing the same song, document. Make sure that everything is documented in your records. In the event the auditors come knocking, that you would have that to be able to justify the item provided.
And just one last thing for me on the documentation side is, remember when whoever the reviewer is at whatever level of an audit that's happening, I feel like the TPEs are, I wouldn't say they're easy, but they're the easiest one of all the audits, I should say, the least worrisome for me. But you look at all the other contractors that audit when we're speaking Medicare fee-for-service, remember, they don't know these patients. So they're basing decisions off the information that we as suppliers are submitting to them. So that's where we have to make sure that information is in those records, that they can clearly understand and justify why a claim has been paid or needs to be paid.
We cannot really talk about documentation without really addressing some misnomers, right?
Yes.
So there's the idea that information. So for example, we know that there's 4 diagnosis codes that are covered for the lymphedema compression items, right? The idea that the diagnosis code written on the order is going to be enough is just straight fallacy, right? We know that the information has to be corroborated by the medical record. So if you only have the diagnosis code written on the prescription, but it's not memorialized within the medical records, these are basic tenets.
Yeah.
But these are some of the questions that I've been asked because a lot of the folks that are in this space are new to the whole DME posts, right? So just for clarity, if the ICD-10 is documented on the prescription, but not in the medical records, then that would not be able to withstand the scrutiny of any auditing entity on the Medicare fee-for-service.
Yeah, and
so
that's not going to work.
Just wanted to dispel that because, it's probably one of the common questions that I've been asked. If you don't bill one of these codes, of course, the claims are going to deny as not reasonable and necessary. But when you bill that, Medicare is expecting that your medical records is going to reflect one of the 4 diagnosis codes. So just wanted to throw that out there while we're talking about documentation.
Absolutely. I'm glad you did. Medical necessity belongs in the medical record, and that includes the diagnosis. And technically, for dealing with Medicare fee-for-service, a diagnosis is not required on the order. They look for it in the medical record.
Agreed.
And physicians and practitioners should be putting that in there. If they're treating the patients for this condition or any condition, they're not putting in there, shame on them. I'd honestly find a new physician, but that's a Ronda opinion. But I'm glad you brought that up. The other thing I wanted to bring up was when you talked about other payers, because there's, we don't know what some of these other payers have in their guidance. And what we have to remember is when information comes out at a federal level, if any other payer is going to follow it, they don't always immediately follow it. It takes time for them to process and implement their own criteria or information, their own claims processing system. It's all different. So we have to be patient, not to say that they won't cover it, but always ask, call them, or review policies or whatever you can do to find the information and get it in writing. Do not take it for verbal information. Anytime you talk to somebody, verbal means really nothing. So get it in writing. Yeah.
Right. And to your point, Rhonda, we had clients that were doing lymphedema compression garment before Medicare made it a policy. So there's some commercial plan that had coverage prior to federal level, right? Yeah. And one thing to also note, and I think we cannot really talk about other payer without really addressing the industry elephant in the room, Medicare Advantage plan, right? So we know that. We won't mention any by name, but we know that as a general rule, right? And this is codified in regs that Medicare Advantage plan cannot be more restrictive in coverage than Medicare. So essentially, Medicare Advantage plan has to initiate coverage for these lymphedema compression items. But what the reg does not mandate is the payment. And the Medicare Advantage plans, unfortunately, has the autonomy to implement things such as prior authorization, which, as we know, is not a thing under Medicare fee-for-service. On the Medicare fee-for-service, you just dispense, bill, as long as you have all the right documentation, including the standard written order. And that's it. There's no authorization. There's no predetermination. But Medicare Advantage plan do have the ability to do that. And in many cases, we're seeing where they're asking for authorization. So I would encourage you, if you are servicing that Medicare Advantage population, whether you're contracted or not, as Rhonda said, do a detailed analysis of what the payer requirements are, making sure that you're adhering to those, because that's what governs the payment. While they have to cover it, they can require an auth. And if you dispense without obtaining an auth, those are grounds for them to deny.
Right. That's really good information that you shared, for sure. So let's talk a little bit about some of the new codes that were released. We know that HCPCS codes get updated in different policies several times throughout the year. We've seen this quite a bit, whether it's changing just a current code with changing and clarifying some language, a description, or adding a new code, deleting codes. But we know they added a few new codes in April that looks like mostly custom. Is there anything that you've seen or unusual or trend? Yeah,
there are some good updates, and really I got to give the UMCA props for really leading the charge in submitting these code changes, because a lot of them just made practical sense. At the last HCPCS coding meeting, I actually submitted written testimony. I'm trying to remember if I did verbal as well, because I was in support of some of these code changes. Anytime there is a not code or not otherwise specified code, or we call a miscellaneous code, that covers multiple products, Rhonda, it becomes a claims processing nightmare, right? And even for us, as we look at data, we pull FOIA data to try and analyze for utilization. It's impossible for us to be able to truly get down to that level of detail with a lot of not code. So I think the request was submitted to get some more specific code to product categories. Some were agreed, some CMS agreed with, some of them they actually disagree with, but there's some changes on, there was revision of existing HCPCS code to make it more aligned with what the products are. And then there were some new codes. So for example, the A6583, they revised the description of that code to remove the mercury measurement. And I think that code actually came over from the surgical dressing policy. None of the other compression wraps had that. So that was just removed. And there's a couple other codes where literally all they did was replace the word pressure with compression. For some reason, some of the wraps had gradient pressure instead of gradient compression. So for example, the A65, 85, 86, 87, 88, those descriptions were just modified to align with just the reality that those codes were really, truly codes that were that had description that didn't match what the product were. The new codes that were added, though, at least some of the new codes that were added. So under the compression wraps, there were codes created, but they were all the ready-to-wear codes. Right. So you had different codes for the legs, the foot, and so on. So the request was, I think there was a misunderstanding that an adjustable wrap, by definition, really would constitute custom, which is not necessarily the case once you understand that nuance, right? So what they did is that they created a couple codes. I think it was A65, 15, 18. And basically what they 19, did with those codes could be up to 19. Yeah. I'm not looking at the exact, just recalling from memory, but specifically what they did, Rhonda, is they created equivalent custom wrap codes to the ready-to-wear codes that were there. So now providers have the ability to build the custom compression wraps, the adjustable compression wraps, where before there weren't options for them to do that. And I think they also did an E6611. So, I mean, the descriptions are there in the policy as to what, but one I think was really important and one that I highly supported were the gradient compression garments, the not otherwise specified codes. Again, we talk about the not codes. Before, there was just one code that covers pretty much all the gradient compression garments, right? For a not code, it didn't specify nighttime versus daytime. So CMS did two things. In the A6519, they added that as a new code, which is now if you have gradient compression garments for nighttime use only. And as you know, Rhonda, the utilization for nighttime versus daytime varies, right? Nighttime is every 2 years. Daytime is every 6 months. Right. So what they did is modify the existing A6549 and add daytime to that for compression garments. And then they created a new code for nighttime, which is the A6519. So now providers have the ability to distinguish nighttime versus daytime garment. And that's important for utilization, right? When you have one code that could fall within the 2-year replacement versus 6-month replacement,
it's a big difference.
It just doesn't make good sense, right, for claim processing. So those new codes, that's really a synopsis of the updates. We don't really want to dive too much into that. The guidance are published on the MAC's website, and perhaps we can even include some links here, Rhonda, for this podcast if we can.
Yeah, I think we can include some links because these contractors do have some good guidance. When you're dealing with Medicare fee-for-service, they have some good guidance out there, even the FAQ. Right. So, you know, I'd actually, when I was a supplier prior to working at BGM, we provided lymphedema, and something you had even mentioned earlier about some payers outside of Medicare that had it in their policy. And we did. We had a patient that was in a commercial plan. I believe she was even Blue Cross. And how I remember this 13 years later, I don't know. I can remember even what she looks like today. I don't know if she's still around. I'm sure she is. But I remember her all because I was the one doing all the fittings with her. And it was her arm, you know. And it was interesting. But we were lucky enough when I was a supplier that we had an occupational therapist that had a specialty with lymphedema. And so being hospital-based was also has its challenges, but that piece was helpful because PT and OT were in the same building that we were in as a DME supplier.
Makes sense.
But the OT, if we had questions, would help. But, we were the ones as a supplier providing the product, billing for the product. But I remember that you obviously do try to fit a patient in a, like an off the shelf, ready to wear type garment. But lymphedema is so unique with the condition that, that medical condition that's why there's a lot of custom out that's available because of that for these patients.
And
it's
for us, Rhonda, like Medicare just made sense when it became a covered benefit, because even if you get into the pneumatic compression device, Medicare required that you use a conservative treatment trial program prior to being eligible for the PCD, but they didn't cover the governments.
Or even those women that went through breast cancer, not that they've improved the way they do those surgeries and treat those patients, because I have a family member that went through that and thankfully never had lymphedema, but it was like you cover certain things but not the other. So it was only made sense that they added this benefit in, and I was thankful for that push. But it's just like anything else. The other thing we have to remember, just because there's lymphedema doesn't necessarily mean they need lymphedema compression, because it's it's like a step therapy. The family member I had didn't need it because they followed the step therapy, which you kind of saw in the PCD policy when it was around, of exercises and things that can be done. But it all boils back to the practitioner, whomever's treating this patient, and following this patient as far as providing, the information for the patient's need. We try so hard as a DME industry to prove everything and be that clinician when we're not. We're providing the product and billing for it. We have to make sure it just meets insurance guidance, to get the insurance to pay for it, if that's how the patient wants the claim to go with insurance.
Just one update on coding, Rhonda, and this is something that, again, you and I always point to the Medicare website because they always get the latest and greatest, but they recently removed the A6584 from the billing guidance with the LTRT because it's a knock code, right? And then I get it, why there would be a need, because you need to specify for utilization. But that's something that suppliers need to be aware of, and that changes. We always recommend that you sign up for the Max listservs or frequently check out their news section because this is where you're going to get the latest and greatest news. But there's just really, it's a good benefit. And we talked about this earlier about if you're considering this benefit category. I mean, some of the compliance thing, Rhonda, you and I, let's walk through very basic, and because time, we would be here for a very long time if we have to talk about all the nuances. But the A55S needs to be updated. Let's probably talk about that just a little bit, and then we'll probably jump into the upgrade situation just to make sure.
The A55S or PACOs, whichever one you're using for your enrollment, your P10, I always call it your cash flow number, right? Because that's essentially what it is. Because if it's not for Medicare, then you've got Medicaid or, Advantage plans sometimes need it. But make sure anytime you're adding a product category or you're no longer providing it, you're updating those services that are being offered. And lymphedema is one that, like Noel had already talked about, if you're going to add it, we need to get it updated. You have 30 days to notify that contractor. So that's either before you're starting the product category to offer it or after, but just make sure you're updating them, updating accreditation as well. Don't assume that things cross over between each other. It's your job as a supplier to make sure everybody has the information they need to maintain that billing number, that P10. And then if there's any licensure or any other requirements pertaining to this, because every state's different with their requirements, it's not always a Medicare, because people will fall, as you've seen too, Noel, is they'll fall to, Medicare doesn't say this. Well, it's not always Medicare. You have to remember those standards, 30 supplier standards say the state law, right? So,
exactly. Spot on. Spot on, Rhonda. We always tell people, it's like the steps you follow. The first thing you do is to look in your state to see if there's a licensure, right? And if there's no licensure, then you move on. If there is one, you obtain the license, then you get accreditation. And once you have accreditation, then you can move towards updating Medicare. Don't dispense not even one product to Medicare beneficiary until those steps are followed, because that can cause you to lose your Medicare number. And as you so eloquently put it, Rhonda, a lot of your other contracts are contingent upon you maintaining your Medicare billing privilege. I know providers who are not even doing any Medicare business, but they keep it active just because they have to maintain it in order to keep their Medicaid contracts or their Medicare Advantage plan contracts or even a commercial payer. They
Correct.
use Medicare sort of as that screening process. So great insights there, Rhonda, as provider look to navigate that step and just build upon the additional guidance that we've given or said earlier. So Rhonda, your favorite topic, let's talk about upgrades and assignments.
Yes. This is a topic we cover in extents, like a common topic. And a lot of times we talk about upgrades because our allowables aren't always the best or suitable to meet our margins. And suppliers think, well, just offer an item as an upgrade for those reasons. And if you go to the supplier manual, I know in CGS, it's supplier chapter 6, Noridian's probably around there. You can look in their table of contents. And then there's the PEM that governs all of that. You cannot upgrade within the same code, guys. They removed that actually in 2016. Prior to 2016, we were allowed to, because Dan Fedor and I, who's in our U.S. Rehab division, we talked about that all the time as an option, and you can no longer do that. So I know you're anxious about talking about it too. So let us know what you've got going with suppliers.
Sure, Rhonda. So I've heard from some nonprofit organization that is monitoring what's going on with the lymphedema, where a patient reached out to them to say, hey, suppliers charging me an upgrade fee to provide to get these items. And my immediate thoughts were, well, no, they cannot do that. And Rhonda, we probably work on a joint article to address that if you're down. I think we could definitely do that. But so, I mean, the idea, and in fact, what the advocacy group actually mentioned is that they build the HCPCS code, the provider, and allegedly they build a separate code. So hopefully we're getting this out to providers just so you're aware that as the rule stands today, you're not able to bill an upgrade within the HCPCS code. So you cannot give them an upgraded, and people get shrugged when I use the car analogy, so I'm not going to mention any car name because I love all cars. But when you get the upgraded, the high-end version of a product, or maybe the product is more expensive than what you're being reimbursed by Medicare, you cannot charge the patient an upgrade fee for that item as long as that item falls within the HCPCS code. So just take that out of your mind. You either need to find a comparable product that gives you the margin you need, or there's one option if you're a non-par provider. So let's talk about unassigned, Rhonda.
Another favorite topic of mine. Yes, non-assigned is another option for those that are enrolled as non-participating. If you have that option, you can do non-assigned, which means you're not accepting the fee schedule. Because if you say, or if you submit a claim and you're accepting the fee schedule and then you charge the patient above and beyond, that is not allowed because you accepted assignment. So no, non-assigned means you're not accepting that fee schedule and you're charging the patient up front. So you set your usual and customary charge, collect from the patient. You're still liable for gathering all the documentation to make sure coverage criteria has been met per all the guidance that's out there. If it's not, that's when an ABN is implemented. No ABN just because it's not assigned. You have to have a valid reason for non-assigned. So medical necessity not met, that's common. That would be what's common in this product category. And then you would go ahead and build a claim non-assigned. That means the patient would get the payment, which is 80% of the allowed amount. And then if they have a secondary payer, it would roll over to the secondary payer for consideration for payment. You're not required to submit the claimant to the secondary. If it doesn't cross over, that's on the patient when you do non-assigned, but that is the option. But as Noel said, accepting assignment and doing an upgrade within the same HCPCS code is not allowed. The supplier manual says that an upgrade is an item with a feature that goes above what's medical necessary. Also, it doesn't, you have to look at the code description. I always say, look what's in that code description. Right. The articles or on the PDAC website, they'll give you all the descriptions. And if it's all within that description, there's no features above and beyond that, you cannot charge for an upgrade. It has to be non-assigned, or like Noel had talked about, finding an item that fits, within the fee schedule. So it's not the brand name,
Right. So, I mean, again, I couldn't resist the car analogy, so I'll keep the brands out of it. But if you have a car, the car is supposed to have the engine, the wheels, of all of these components that consist that makes it a car. But if a brand has some luxury features that doesn't serve the purpose of the car is to drive to get you from point A to point B. So if you have a car of a certain brand that gets you there, it's a car, right? And if someone wants a more updated and a luxurious brand car that has features like self-driving mode, all of those are convenience features. So you cannot upgrade within the HCPCS code of a car. So compression, bringing it back to compression garment, not because one manufacturer might make a better product or a manufacturer has a better brand recognition name, so their product is a little bit more expensive. You cannot charge the patient the upgrade. So the assign is the only way that you can actually recoup additional costs associated with that. And again, this is not an assignment webinar, but make sure that you follow the rules. There are certain requirements, notifications, and some exceptions with Medicaid. We're not going to get into that, but just know that those are your options. So do not do the ABN within the HCPCS code, upgrade within the HCPCS code. It's not allowed. Assignment is only an option for you if you're a non-PAR provider, which allows you to do assignment on a case-by-case basis. And if you are not if you are a participating provider, at the end of this year, you might want to consider changing that. Right. That there's an opportunity at the end of the year to change it to a non-PAR. We're not going to get into assignment because Ronda and I will be talking here forever, but you don't see any benefits of being a participated supplier under the DME benefit. Physician, it might make sense because of the additional reimbursement, but under DME, you get reimbursed the same whether you're a PAR or non-PAR provider.
I've had suppliers even say, if I go ahead and do these upgrades, sorry, that was my chime, I'm sorry, but I have had suppliers say, what if I go ahead and do these upgrades or just do this? What are my risks? There's a lot of risks with this because of all of the mandates that are out there as far as filing a claim. What we have to remember, one, is just because when we file a claim and a claim pays doesn't mean that was a success. We have to make sure we're filing it correctly and it pays correctly. Great. If we don't follow those policies that are set out there, then that's on us to make sure that we correct that or voluntarily refund. It can take a whistleblower, and then it opens up this whole investigation, or just any audit. Don't think of just a prepay audit. Any auditor look at claims because they are following. Because Noel and I sit on councils with the different contractors, and they follow claims data. They follow all of that. Right. So they're following all of this. And if they see any trends or issues, they will stop it and let CMS know so they can know how to move forward. So don't just assume that it's okay. Make sure you're keeping your business safe.
Patient complaints to Ronda, right? Yeah. I mean, if you charge a patient an upgrade and the patient listened to a webinar or an advocacy group said to them, oh, this is not allowed. Guess what they're going to do? They're probably going to call 1-800-Medicare before they call you as a supplier, right? And now you're in hot water because you did something that is perceived to be wrong. And that is actually grounds for your P10 to be terminated. And that's clearly articulated in the regs. So just be careful what you're doing, protect your business, and make sure that you're doing the right thing all the time by your customers, by your patients, and also by the Medicare Trust Fund.
So as we wrap this up, because we don't want to end on a scary note, because it's, we don't want to scare people. That's not our intent by all means. But, this is an area to consider. Just like Noel had mentioned at the very beginning of this, is to look at what your state requirements are. Look and see if it's suitable for your area and your territory. Do some legwork as far as finding out what your referrals are doing, where these referrals are going. If there's a need, certainly do it. I mean, don't hesitate doing it, and educate all your staff on this product. From the front end intake all the way to billing and any of the clinicians that are involved. So don't shy away from it. If it works for you, it's great. And then get some education done, whether it's internally or from one of the professors here, right?
I mean, Rhonda, you said it great. And I know we try to really keep these very limited, but you get Rhonda and I talking about these things, we'll probably be here all day. But we really wanted to keep this very concise and succinct to get you helpful information. Hopefully something we've said has sparked an interest and trigger additional research. There's tons of information that's available on the MAC's website. I do believe it's a good product category to go in. Just make sure that you have your fitters, make sure that you have good return policies. And a lot of those are facilitated by the manufacturer. So it's a good business model. But you just, like everything else, make sure you do your due diligence, as Rhonda said, and just go in there with the idea that you are going to be overly compliant, and you're going to make sure that you follow all of the requirement, published regs, and be as conservative as possible, because there is opportunities for growth and expansion. And from what I'm seeing from providers, there are margins that are sustainable in many products categories. So look into it. We encourage you to do it. We want to make sure that there's access to the care for patients out there. This is kind of what we do. But we want to make sure that when you get paid, you keep the money in the back.
Right. Exactly. We want to protect you too. So this was great, Noel. As you said, I always love doing sessions with you. It feels great. It's just fun. We have a lot of fun with it. So thank you. And if you have any questions, let us know. We will put some links in the show notes to these different that we talked about with CGS and Noridian. And if there's anything else we find, so you have easy access to everything. And thank you for listening. We appreciate it. Anything else you want to add before we wrap up?
No, Rhonda, always a good opportunity to be with you. And I always love it. It's always fun and interactive. It's crazy how much time has passed. And I feel like we just started talking like 2 or 3 minutes, but always a good opportunity to be with you. I thank you, and a great opportunity to be in the ear of the VGM members. You guys are appreciated. And kudos to VGM for always trying to bring relevant content to their listeners and their members that are relevant and are actionable. So again, thank you, Rhonda, for the opportunity, and they know where to find us if they need us.
Yeah, thank you, and it's a great partnership. So thank you, Noel.
Awesome.
Thank you. Yep. Goodbye, everyone.
Bye, everyone.